Hi, everyone, and welcome to another edition of Next Gen MD with Dr. Lily Johnston. I'm Kim McNicholas with the Global P.A.D. Association, and today we're talking about lipids, everything you want to know about lipids. We want to talk about cholesterol, right? We want to talk about the basic lipid panel versus an advanced lipid panel, what matters, what doesn't. And I know Dr. Lily Johnston has very strong opinions about what is important and what's not. So overall, Dr. Johnston, why does the lipid panel matter?
Well, thanks, Kim. It matters for two big reasons. One is that everybody thinks that it matters, so everybody wants to talk about it.
Mhm.
And we need to understand what really is important with a standard lipid panel and what's not. And the second thing that's really important is understanding what it does and does not tell us.
Yeah.
So let's dive right in.
Okay. So can what are the biggest misconceptions when it comes to
Well,
that lipid panel?
sure. Everybody talks about good cholesterol and bad cholesterol, but
Right.
true or false, the cholesterol molecule that's in the LDL, which is what people think of as the bad cholesterol, and the HDL, which is what people say is good cholesterol, are those cholesterol molecules different? They're not. That's the same cholesterol molecule. So, really, let's step back and just take it from first principles because cholesterol by itself is just sort of a waxy substance, a waxy molecule, a fat that our body absolutely needs. It is part of our cellular membrane. It is the precursor to many of our steroid hormones. So, it's a very essential molecule, and every cell in our body can make its own cholesterol. So we absolutely need it. But what makes it good or bad isn't really the cholesterol itself, it's what carries it and where it goes. So I like to think of cholesterol as a box, it's a package that is being carried. And what really matters is what vehicle is carrying it. So is it a UPS truck? Is it the Amazon Prime truck? Is it a dump truck? What kind of vehicle is carrying this box and where is it going and what is it doing? That I think is really the key to unlocking how you think about a lipid panel.
Yeah. And so what carries? I mean, yeah, you talk about, it could be the porta potty carrier, it could be the Amazon truck, whatever it might be. But in terms of the carriers inside your body, what is the difference between good or bad in terms
Sure.
of the carrier?
All fats in our body require a protein or some other molecule to carry them around in our water-based bodies. So these cholesterol molecules are carried by something called a lipoprotein. And that is a protein whose job it is to traffic around or drive around these cholesterol molecules. And that is what defines the low density lipoprotein, the LDL, the high density lipoprotein, or HDL. And those are really the kind of trucks that are carrying this cholesterol back and forth throughout our body to the places that need it.
Okay. So you have the basic lipid panel. Can you walk us through that?
Sure. Your basic lipid panel, and truthfully, these are not always done fasting, but I truly prefer that in my patients, they get a fasted lipid panel, and we'll talk about why. But a traditional classic lipid panel will have a total cholesterol number. So that's like taking a satellite picture of the freeways during rush hour. It's all the trucks, all the cars, all the everything lumped into one big number. Not always terribly helpful, but you get it. And then we have a breakdown of triglycerides, LDL cholesterol or LDL-C, HDL cholesterol or HDL-C, and sometimes we get some other breakdowns in there as well. But typically, we'll get the triglycerides, the total, the HDL, and the LDL-Cs. That's what comes in a classic lipid panel.
Okay. Can we talk about each one of those?
Sure. So we already talked about the total cholesterol. That doesn't
Right.
mean a whole lot to me. And honestly, Kim, what is the biggest impact for me in terms of the lipid panel are the triglycerides and the HDL-C.
Okay.
If you'll remember, those are two out of the five components that make a diagnosis of the metabolic syndrome. So elevated triglycerides and low HDL-C are two out of those five components of the metabolic syndrome, which is a diagnosis of insulin resistance that ultimately will lead us on to prediabetes and diabetes if not managed. And this is why I like a fasted lipid panel, because interpreting triglycerides, which are molecules trafficking lipids very quickly throughout the body, triglycerides will always be elevated after a meal. And I don't have a great sense for what that number means relative to when somebody ate and what they ate, because that will also impact that triglyceride number. So a fasting lipid panel allows me to interpret that fasting triglyceride number and the high density lipoprotein C, or cholesterol content. Hello from the mascot. Thank you.
Hey, you know what? Your cat has fans already, so keep them coming. Keep them coming.
Absolutely. That's why she got a little cameo. We'll not pretend like she's not here. So back to triglycerides and HDL. Those are the two things that really mean the most to me about that lipid panel. And, they're not really about the cholesterol. They're about this marker of insulin resistance and metabolic dysfunction. So this is why lipid panels are actually super powerful, and it's not for the reasons that people think. We also have the LDL-C component of that lipid panel, which is interesting to a first approximation. It can certainly provide clues if maybe a patient has a very high level about, do they have an inherited disorder of lipid metabolism like familial hypercholesterolemia, or FH, which is about heterozygous 1 in 100, 250. So that's not super uncommon, and we can detect that, or at least have a suspicion with the LDL-C number. But that's only the first part of that puzzle, because it just tells us about the number of boxes. It doesn't tell us about the trucks that are carrying them, how many cars there are, and how concerned we really ought to be. And that is how we will lead into advanced lipid testing.
But before we go into advanced lipid testing, what should the conversation look like between especially a primary care doctor and a patient? Because when the patient goes in, for example, with my dad, and this will lead into the advanced lipid panel, the doctor actually told my dad that when he presented in urgent care with what he thought was heartburn, I interpreted it as chest pain. Turns out I was right. She told us that she didn't have a diagnosis code to test him for heart disease, because she felt as though, because his basic lipid panel was all normal, that there was no way that he could be at risk for a heart attack. Wrong.
Yeah. Lipids are part of the milieu, the soup that creates plaque, right? But to say that lipids are the only thing that causes plaque in the artery is sort of like saying trees cause forest fires. Well, yes, you have to have some trees to have a forest fire, but you can have a sparse forest and still have a fire. It's not the thing that starts it, and it's not necessarily the thing that perpetuates it or causes it to rage out of control. So we do always have some component of lipid found in the plaque in the arteries, but it doesn't have to be this huge, terrible lipid panel for it to be a problem. And there's a huge misconception that cholesterol is the only risk factor, and smoking, right? I think people can all acknowledge smoking. That's been a long-standing one. But otherwise, like, well, I don't smoke and my LDL is normal, I must be fine. And there are many more pieces to the story besides that. And it's absolutely possible to have a quote unquote normal, and we can talk about normal versus optimal, but normal level of low density lipoprotein cholesterol, LDL-C, and still have significant atherosclerotic disease.
Yes, before we go into the advanced lipid panel, which I'm just chomping at the bit to get into, normal versus optimal.
We are talking about patients here largely with peripheral arterial disease, or P.A.D. And by definition, a patient with P.A.D. is called what we call secondary prevention. That means we know they already have the disease. Mm-hmm. Therefore, we are trying to prevent another event worsening of the disease, which means we're going to be a little more aggressive. So a patient with a diagnosis of P.A.D. or coronary artery disease should have an LDL-C of at least less than 70 milligrams per deciliter. That is the current goal. Many in the preventive cardiology space would actually argue even lower, perhaps less than 55 milligrams per deciliter. But right now, 70 is the guideline, or we can also target a reduction by 50% of your baseline. So
Mhm.
patients will say, I have PAD, but my cholesterol, my LDL is normal. It's,
Mhm.
call it 85, right? Less than 90 is sort of the standard for somebody without a diagnosis of PAD, but most people would say an LDL-C of 85 is not that bad. Okay, well, it wouldn't even be less than 70 in that patient. We would actually target a reduction of 50% in that patient, really to meet our current guidelines. All that to say, you can have an adequate LDL-C for the average person walking around, but
Mhm.
when you get diagnosed with PAD or coronary artery disease, we now have a new target, a new goal, and it's much more aggressive.
Okay, moving into the advanced lipid panel. I'm going to describe to you what my dad's dietitian, she has her doctorate in diet. I don't know exactly how that title is used, but she got her PhD as a dietitian. And she described to my dad, she ordered an advanced lipid panel. And she told him that she doesn't like the basic lipid panel because it's all about just quantity. It's not about the quality. It's not until you get this advanced lipid panel that it breaks down the cholesterol to show the large fluffy ones, the number of large fluffy ones versus the small ones, which she says when they become oxidized by trans fats and free radicals and such, they can eke into the damaged areas of the arteries and push them out. And so for my dad, while his basic lipid panel was normal, his advanced lipid panel showed he had a very large number of the small, dense LDL particles that she called the troublemakers. So I would love to hear your take on it. Any corrections that you would make or clarifications that you would make to that as well.
I think that's a great way to frame it, Kim. The advanced lipid panel really now measures the proteins, those lipoproteins that carry the cholesterol molecules around. So now we're actually looking to see how many dump trucks do we have versus how many Amazon Prime trucks, right? Everybody likes the Amazon Prime truck. That carries cholesterol back to us about away from the artery, out of the plaque. Those dump trucks, the porta potty trucks, those are all carrying those containers into the arterial wall. And some of them are much more likely to cause trouble than others. So think of it as, the truck driver who's had his license revoked 4 times for bad driving. That person's much more likely to cause an accident than somebody who is, just doing a good citizen service by taking out the trash in the community, right? So the advanced lipid testing is a more in-depth analysis of which particles, which proteins are carrying and how many there are and how big they are. And that really gives us this breakdown of how many trucks do we have, not just how much cargo do they have, and how likely are they to be contributing. As we have learned more about lipoproteins and these particles, those small, dense particles are much more atherogenic or likely to cause plaque than the larger ones. And it's not really about getting stuck based on size. It just is this understanding that the small ones have longer transit time and more likely to be oxidized, more likely to create the accumulation of those oxidized phospholipids in the cell wall or in the endothelial membrane and form that plaque or progress and accelerate the development of pre-existing plaque.
And these ones, they're the ones that go and they're more attracted to the damaged areas of the arteries, the inflamed areas, such as what would be inflamed by toxins from cigarettes.
I think the way I think about it is our lipoproteins are floating in and out of the endothelium or the lining of our blood vessels all the time. They are
Okay.
so small that they just float in and out naturally. But what makes them get stuck there, right? It's more like Velcro.
Yeah.
What is causing them to really come in but not go out, not
Yep.
egress? And it is the inflammation and the active oxidation that does create this signaling cascade of all these molecules that both allow those particles to get stuck there and then also them and create more inflammation. And it becomes this feed forward process that is self-perpetuating. And for example, some of the lipid lowering medications would be one way to think about partially addressing that inflammation and the number of particles that are available to get stuck.
And so, with all of this, what is the real takeaway for the patients and understanding the lipid panel, the advanced lipid panel, where cholesterol comes from? Just give us the summary as to what's important for patients to know and how they can take action on this information.
So let's talk about a few things. The first one is that your lipid panel also speaks to your metabolic health, not just your lipids. So if you have abnormalities in your triglycerides, so optimal for me is less than 100. I heard somebody at a conference this weekend say his was actually less than 70. So pretty aggressive fasting triglyceride number. And if your HDL is low for your sex, then you have metabolic syndrome or 2 out of 5 components of it. And that deserves its own conversation above and beyond statins or lipid lowering drugs, because those medications don't impact those two things very much, but your nutrition does. And that is worth its own conversation. The second point is, just because your lipid panel looks green in the green boxes on your lab report doesn't mean that it's optimal for your diagnosis and your personal goals. For example, if you have P.A.D, your number where we would target your goal might be different. It probably will be. So understand that just because it looks normal in the range on your lab reference sheet doesn't mean it's where we want you to be to minimize that accumulation of oxidized particles in your plaque to stop it from progressing. And the third thing is, if you are interested in understanding exactly what's going on and having a true metabolic conversation, ask for an advanced lipid panel test. And if your physician won't order it, you are actually empowered to do this. And I don't have the QR code for you today. I'm really sorry about that, but I can point you in the direction of places where you can order your own testing. Cash, you can just go in, order it online and walk into Quest or LabCorp and get that drawn so that you can now have this information and bring it to a physician or a nutritionist or somebody who has an understanding of what that means and can help you work through that so that you can really prevent progression and accumulation of plaque.
It's interesting. We used for my dad Boston Heart Diagnostics. I love their advanced testing. If you can find someone in your area that performs those testing, the blood markers, it's incredible because they even give you a pretty thick booklet that breaks down all of the results for you. And that truly was what changed my dad's life and actually got him to take his health into his own hands and start making the critical changes, because he's a data guy. He wants to see the numbers, specific numbers. And then he wants to see those numbers change over time based on his actions. And so for him, that really works. The thing was that his cardiologist, one of them, now we've gone to quite a few to try and get second and third and 7 opinions, just because we weren't happy with a few in one network. But we were finally able to get one that knows a lot about metabolic medicine. But the first one said, oh, I don't know even how to read the advanced lipid panel. I don't know what to do with it. That's why I don't order it. It means nothing to me. And my head just about exploded, because listening to you, look at how important it is in making critical decisions about your patients and any patient's health.
Yeah, that's a great point. And it reminds me that we actually haven't talked about perhaps the most important number that is the easiest one for people to kind of wrap their brains around. We talked about particles, but we didn't talk about apolipoprotein B or ApoB. Yeah. And this is such a key metric because it gets really confusing about the dump trucks and the porta potty trucks and the Amazon Prime. And there's all these trucks and like they're big ones and small ones, and I don't remember. And then there's the triglycerides, and it all gets very confounded. But if you wanted to sum all that mess up into just one number, every truck that delivers plaque, or excuse me, that delivers particles into your plaque, into the arterial wall and deposits them there, has this tag on it that's called apolipoprotein B. So it's on the low density, the intermediate density, the very low density lipoproteins. All of them have this ApoB molecule, and it is a summary number that tells us truly about risk, much more so than the LDL-C. Now, many people will have ApoB and LDL-C that track together. That's fine, but many people don't, and that is what we call discordant. It's often suggestive of metabolic dysfunction because it means we have more small, dense LDL particles, and the cholesterol is disproportionately in many particles rather than in a few. But that ApoB number is something that is very powerful because it's just that one number. So if you had to just get one thing, I would say get an ApoB if you wanted something besides your standard lipid panel. The next piece to remember is you can see great shifts in the particle distribution on that advanced lipid panel and have a lot of reinforcement for good behaviors and good choices that wouldn't be reflected in that standard lipid panel, right? Your LDL-C hasn't changed, but you've switched from small, dense LDL particles to those larger, more LDL particles that are less likely to cause trouble. And that switch we think is meaningful. So there are patients who say, well, I haven't seen any change. Why am I on this medicine? It hasn't done anything for me. Well, actually, if we look at your particle distribution, you've switched from what we call, one pattern to the other, and your particles are now less dangerous. So you have made good progress, but you don't always see that on the standard panel. And for that reason, also, that advanced testing can be more helpful for patients and for their providers.
That's why we always talk about with our patients that you could have high cholesterol in a basic lipid panel and not be at risk for cardiovascular disease and vascular disease. And you could have normal cholesterol in a basic lipid panel and be at high risk. And so it really comes down to those additional markers that you've been talking about, particularly into the advanced lipid panel, that people should have a productive conversation with their doctor about it and even get a second opinion if their first doctor isn't experienced in advanced markers for lipid testing. So very important, don't you think?
Absolutely.
Yeah.
Absolutely.
We also have a question that patients ask all the time. I'm not sure if you could answer it. It's one of those probably very loaded questions, but how do these lipids, how do they decide where to camp out in the body? I know for diabetes, they seem to really, everything seems to like the smaller vessels down in the calf and the foot. But gosh, some people have heart disease. Some people will have a bunch of plaque buildup in their heart, others in their neck, sometimes both, sometimes in their aorta, sometimes in their groin and their thigh, sometimes even just in their foot, whether it's fresh clot or whether it's the atherosclerosis indicative of general heart disease or peripheral artery disease. Is there anything out there that talks about this or can give us any extra intel?
A little. So atherosclerosis is, of course, a systemic disease. And if you have plaque in one arterial bed, we assume that you have it in all of your arterial beds to some varying degree. But as you point out, some people present with a heart attack, plaque in the arteries in circulating around the heart called the coronaries. Some people present with a stroke or plaque in the carotid arteries that go up to the brain. Other people present with leg pain or ischemia in the leg. And why that is, we don't completely understand. As you correctly mentioned, diabetes is a small vessel disease predominantly. It certainly disproportionately affects the small vessels before it then impacts larger vessels. Renal insufficiency or kidney disease, kidney failure also has a liking for smaller vessels because it creates what we call medial calcinosis or deposition of calcium in the media or the middle layer of the blood vessel. So the smaller vessels tend to be more sensitive to that disruption. And historically, smokers were considered to have more central atherosclerosis in the extremities. So aortoiliac occlusive disease was more common in smokers than in other patients, but everybody can have a different presentation. And if I knew exactly who was going to get it in which vascular bed, I would be a millionaire by now. So we don't totally understand why some people predominantly get it in the carotids versus the legs. But we do know that overall it's a systemic disease, and that risk of mortality is absolutely related to the presence of that same disease in the coronary circulation around the heart and in the brain for heart attack and stroke risk, respectively.
And so, gosh, this has been a great discussion about the basic and advanced lipid panels and what to talk to your doctor about. And I assume upcoming conversations, we should be talking about Lp(a), which is another marker that's very important. We should talk about liver production versus cholesterol reabsorption, because that could be a big determinant whether or not a statin may work for you or not. And I maybe would get into statins a little bit in that one, or maybe that would be part of the general statin discussion. But we have a lot to talk about going forward. So make sure you like this video, subscribe to our channel, youtube.com/the way to my heart, and check out the Next Gen MD playlist. You want to get, click the little bell button to get notified when we put new videos in there and when we're going live, because this is incredible information and we have more to come. I don't think you'll find this information anywhere else in the way that we're presenting it, because we have a very special doctor. I don't think I've ever seen another vascular surgeon with this extensive metabolic experience that you have. And so thank you so much, Dr. Lily Johnston. If people want to get a hold of you, how can they reach out?
You can reach me at LinkedIn, so /LJohnstonMD, or you can find me at vascularhealthinstitute.org.
Fantastic. And if you want to call the Leg Saver hotline for the Global PAD Association, 1-833-PAD-LEGS, up there on the screen. And it's 1-833-723-5347, or PAD Legs. I'm happy to get you in touch with Dr. Johnston as well. Thanks everyone for joining us. I appreciate our producer Josh for also making this magic possible. Have a great day, everyone.
Thank you.